What is osteomyelitis? So osteomyelitis is basically infection to the bone. Okay. Inflammation secondary to infection is the right word. Okay. So what happens in the bone basically? So there is, as I said, there is inflammation, edema and everything secondary to infection. The bones are very healthy, mature bone is very resistant to infection. But at the same time, if infection comes, it is very difficult to remove it from the bone. Why? Because of the scarcity of blood supply. Okay? So usually bones have nutrient arteries through the shaft and goes to the metaphysis. What happens at metaphysis? There are hairpin loops or hairpin bends, and there is blood viscosity is high, so there is sluggish blood flow. And something I read also, so it is scarcity of phagocytes in the metaphysis. This contributes to metaphysis being the most common area for osteomyelitis. Okay. So in the bone there is diaphysis, metaphysis, epiphysis. Metaphysis is the most prone to infection. Can it cross the growth plate? So like in children there is epiphysis, metaphysis, and there is a growth plate in between. So can it cross growth plates? So my point is there contiguous spread? So there can be. Can it cross the joint? Can it cross the metaphysis and go into the joint in adults, causing septic arthritis? Yes, it can. Okay. So what are the causes? So it is a microbial invasion, bacterial being the most common cause. So bacterial may be kya? So Staphylococcus aureus is the most common cause of osteomyelitis in general, except in some few scenarios, like diabetic foot. Diabetic foot में क्या होगा? So diabetic foot means it usually happens in obviously diabetes. So diabetes में क्या होता है? Vasculopathy. So vasculopathy causes reduced blood flow to the lower limbs का distal aspect. So what happens there? Again, more scarcity of blood flow and increased sugars, which can lead to infection. So it is Pseudomonas that affects diabetic feet more commonly. In sickle cell anemia, it is Salmonella. Okay, I don't know why, but it happens somehow. In IV drug abusers, it is again Pseudomonas. Okay, so these are the causative organisms. Then types. Now, osteomyelitis is classified based on time duration and based on level of involvement. So based on time duration, it is termed acute, subacute and chronic. Okay. Secondly, there is, so this classification is called Lew and Waldvogel classification. Okay. LEW and Waldvogel classification. Okay. Then there is another classification called Cierney and Madar. This is more commonly used as it is helpful in the management. Okay. So there are 4 types to it. First is superficial. First is only confined to the medullary cavity. Second is cortex involvement. Third is locally invasive. Okay. And fourth is your diffuse. This is Cierney and Madar classification of osteomyelitis. When do you call it acute? When do you call it chronic? So I'll tell you something. Basically, previously, in previous studies, you used to classify it based on time. So 2 weeks you used to call it acute, and then it used to call it subacute. There used to be a classification where it used to say 6 weeks also. But now it is not acute or subacute or chronic based on time. It is acute and chronic based on the presence of sequestrum. Okay? What is sequestrum? So sequestrum is dead bone. Dead bone which is eaten up by the bacteria. Okay? So how does dead bone appear on an X-ray? It is more white. Pearly white is the term. Okay? So a bone which is more white than a bone in the X-ray is usually sequestrum. What is involucrum? New bone around the sequestrum. So the body tries to enclose the sequestrum, the dead tissue, and that is called involucrum. This we'll talk again when we'll talk X-rays or MRI or anything. First, what are the clinical features? Pain, fever, swelling. What is the hallmark of chronic osteomyelitis? So a chronic discharging sinus with a history of bone fragments coming out of the sinus. That is your hallmark of chronic osteomyelitis. Okay. So these are the symptoms. What are the signs? Will there be tenderness? Will there be tenderness? Tenderness will be there. Swelling will be there. Localized redness will be there. There will be the presence of a discharging sinus. Okay? There will be, if it is nearby a joint, there will be reduced range of motion of the joint. Okay? Due to the swelling and the pain and everything, there will be reduced range of motion at the joint. Okay? So how do you classify? You have already classified it. You have already seen the clinical features. Now diagnosis. So before that, you'll go for some blood investigations. What are the blood investigations? Okay. So first of all, we'll go for a common approach, that is CBC, leukocytosis, number one. Then yes, acute phase reactants. What are acute phase reactants? ESR, CRP. Okay. Then your blood culture, because usually osteomyelitis is hematogenously spread. So it will be there in the blood. Okay. This is what you will order on the investigation purpose in the blood. Now what will you do for imaging? So X-ray. Now X-ray will not show it until around 21 days or more than 30% of involvement of bone. Before that, X-ray will not be able to show you signs of osteomyelitis. So what is more specific? MRI. MRI can tell you within a day. What will it show you within a day? Marrow edema is what it will show you. Okay. What else can you do? Bone scan. Okay, no. You should do a technetium 99 scintigraphy. Okay. So relative uptake of technetium 99 will be higher in osteomyelitic bone. Okay. Then how do you treat it? So IV antibiotics. Okay, IV antibiotics. What is empirical antibiotics and what is definitive antibiotic therapy? So broad spectrum antibiotics for broad spectrum cover, so that everything can be covered before the culture report comes, which shows you the specific microbe and its sensitivity to antibiotic. Then you will give definitive antibiotic therapy. Okay. So if penicillin sensitive Staph aureus, you will give penicillin. Okay. So similarly, whatever. These days, third generation cephalosporins are in, and then there is linezolid, teicoplanin. You can give higher antibiotics as well. Okay. This is your medical management. But in osteomyelitis, it is usually a combination of medical and surgical approach. So that is a multidisciplinary approach to osteomyelitis. So what will you do in surgical basis? So first of all, basic, if there is a superficial collection in ultrasound, you do an IND, incision and drainage. Okay. So you remove the pus which is coming out. I forgot to mention one more investigation which is very important in osteomyelitis. That is something known as sinogram. What is sinogram? Inject the dye, get an X-ray through the sinus. Okay. So that will tell you that how much is the reach out of the sinus. That where is it opening up in the bone. Okay. So that you can do. Now, what do you do in treatment? You have given IV antibiotics, surgically you have given IND. Now, what else can you do? What else do you do for the bone? You were right. So, there is sequestrectomy. So, sequestrectomy and saucerization, they are narrow terms coming under a broad term called debridement. Okay. So, what is debridement? Dead necrotic infective tissue removal. Okay. Where do you stop? Until you see paprika sign. What is paprika sign? Fresh bleed. That means whatever is coming up is a healthy, viable tissue. What are the 6 E's of debridement? So that you study. Okay, I'll ask you tomorrow. So what is sequestrectomy? Is removal of the dead necrotic bone. What is saucerization? Saucerization is increasing the surface area and making up a saucer-like approach to the bone. Do you fix the bone? Like you have done debridement or sequestrectomy or saucerization. Do you fix the remaining bone? If you feel the stability is compromised, yes, you fix it with an external fixator. If it is not, you do not need to do that. Plus, sinus tract excision. Complete sinus tract excision. Why? So it can cause infection again. Why complete? Along with the walls and send it for biopsy. Why do you do that? Because the walls of the sinus are prone to getting squamous cell carcinoma. So you need to send that for biopsy to look for whether there is squamous cell carcinoma as well or not. Okay? That you can do. Now another approach you can do is to put antibiotic beads inside. What do you mean by antibiotic beads? So basically, so the concept is that if you want that much amount of antibiotic in the bone, you cannot get that without causing systemic side effects if you give it through the systemic approach. समझ रहे हो कि systemically अगर दोगे उतना तो your body will have side effects rather than getting treatment at the local site. So you put antibiotic beads locally. There is something known as antibiotic cement, which is called PMMA, polymethyl methacrylate. Okay, that you combine with vancomycin and gentamicin and you put it inside. Now you will tell me what is the dose of vancomycin and gentamicin in antibiotic beads. So this is called high local antibiotic concentration beads. Okay, so that is something you can do. Again, there can be osteomyelitis secondary to a fracture, open fractures. That is why we study open fractures extensively, because there are chances of osteomyelitis. So there can be a role of some flap cover or skin grafting. So you need a plastic surgeon along with you most of the times when you're doing the surgery. Not saucerization or sequestrectomy, but extensive approach if you are taking, then you need a plastic surgeon to help you, okay, with the flap or SSG. Okay. Now what is periosteal reaction? I forgot to mention. So periosteal reaction is elevation of periosteum either through a tumor or through the pus, and that will show up on the X-ray. So one of the differentials of osteomyelitis is tumor and TB, or better yet, one of the differentials of a tumor is osteomyelitis, because osteomyelitis can look like almost all tumors. Okay. What else? So then there are two specific types of osteomyelitis that you should know. One is Gar's osteomyelitis. What is Gar's osteomyelitis? GARRE. So Gar's osteomyelitis is the osteomyelitis of mandible at the jaw. Usually happens at the angle of the mouth. So they are self-contained osteomyelitis, meaning there is a layer of bone around the collection inside. So there is osteosclerosis around the collection. So it is well enclosed subacute osteomyelitis which can be treated with antibiotics. Then there is another one called Brody's abscess. Okay. So Brody's abscess is another type of osteomyelitis where there is localized infection enclosed by bone at the upper end of tibia. What you can do is you can remove that collection and put cement in it. That is the usual treatment for Brody's abscess. Complications: extensive infection, diabetic foot can land up to amputation, pathological fractures, bacteremia, septicemia, septic arthritis. I think that's it.